Welcome to the MI Mental Podcast, the Doctors in Court edition. My name is Sabine Thunderson, a general practitioner, and today I'm also a proud volleyball mom. This is the case of a cardiologist that did not share his findings with a general practitioner, case number 9. If you like these podcasts and listening to what actions or inactions bring doctors to court, please like and subscribe and give me a review. I base the majority of these stories from real court case findings in countries like the Netherlands and the UK. In order to respect the privacy of both plaintiffs and the defendants, I refrain from using full names. Also, I use this podcast not to vilify the health professionals who work day and night to keep people safe and healthy. I use this podcast to learn from things that happen every day and that can unfortunately land a doctor in court. In this case, a cardiologist has been taken to court by family members of a patient who had heart disease and also was diagnosed with diabetes and obesity. The patient was in the care of the cardiologist for over 5 years, and during that time, the patient's general practitioner referred him back to the cardiologist for chest pains, which needed further investigation. The cardiologist thought otherwise and stated the chest pains were most likely due to stomach issues. After a few failed attempts for further investigations to take place by that cardiologist, the general practitioner decided to refer to another cardiologist in another hospital. At that second hospital, the cardiologist confirmed that the chest pains were indeed of cardiac nature, after a coronary angiogram showed a severe blockage of one of the coronary arteries to his heart. The patient was put on a waiting list for a stent but died shortly before the procedure. Now the family of the patient are suing the primary cardiologist who failed to investigate further and suing him for negligence. What will the judges rule, do you think? What would you rule? Leave your comments or suggestions. Let us dive into the case. The plaintiffs are the children of the patient, Mr. D, who I will refer like this moving forward. Mr. D died at the age of 64 on November 2020. Before his death, he had been in the care of the defendant cardiologist, who I will refer to as Dr. C moving forward. The plaintiffs accused Dr. C for being negligent and not offering adequate care to Mr. D, their father, particularly with the knowledge that Mr. D was a high-risk patient who suffered from a previous heart attack and he was diabetic. Before we continue with the case, for context, let me highlight why it is important to understand what is meant by being a high-risk patient. According to an article by Holthouse and colleagues published in the 2021 Global Heart Journal on the risk factor clusters and cardiovascular disease in high-risk patients, the most important risk factors in cardiovascular disease are obesity, smoking, high blood pressure, dyslipidemia, and type 2 diabetes. Furthermore, the coexistence of two or more risk factors, known as clustering, is associated with an increased risk of cardiovascular disease. So with that forming the context, let us get back to the case. Remember, plaintiffs accused Dr. C for ignoring the very high risk profile Mr. D had and not taking his chest pain seriously, nor acting on Mr. D's general practitioner's request to do further investigations. Due to this, Mr. D was prevented from receiving a timely, life-saving treatment. The plaintiffs also accused Dr. C for not documenting the consultations with Mr. D accurately, so much so that Dr. C failed to provide sufficient information to Mr. D's general practitioner regarding the follow-up appointments and what plans or decisions had been made. The judges ruled for the plaintiff and gave Dr. C a warning. These arguments for their judgment are as follows. First, let's look at the facts. Mr. D suffered a heart attack in 1995 and in 2004 had been under the care of cardiologist Dr. C. In 2012, Mr. D was admitted at the heart unit for an elective or planned procedure called percutaneous coronary intervention of his left anterior descending artery. This procedure, in short, is used to treat a blocked artery that supplies the heart with blood. A balloon is inserted in the area of the blockage to remove or dilate the blocked section of the artery. A percutaneous coronary intervention, or PCI, is also known as an angioplasty with a stent. In his medical records, it is noted that Mr. D also suffered from type 2 diabetes, severe obesity, with a body mass index of 38.1. Now remember, a normal body mass index falls between 18.5 and 24.9. He also suffered from high blood pressure and sleep apnea. A year after the procedure, Mr. D was diagnosed with peripheral artery disease, meaning that an artery to his lower limbs was narrowed or blocked. In 2014, he was diagnosed with stable angina pectoris. And stable angina pectoris is a condition to describe chest pains or discomfort of the chest that occurs with light activity or emotional state. From 2014, Mr. D attended Dr. C's clinic for follow-up appointments twice a year. In September 2017, Mr. D attended a follow-up appointment at Dr. C's clinic for a regular checkup. A month later, Mr. D's general practitioner sent him back to Dr. C with a referral letter and a request to not wait for another 6 months to pass in order to review Mr. D, but to see him sooner because of persistent chest pains. Dr. C saw Mr. D sooner than scheduled, and further investigations in the form of an MRI were requested. 2 months later, in January of 2018, the cardiologist sent a letter to Mr. D's general practitioner in which he states, "Patient has very localized thoracic pain, like knives stabbing him, and at times some pressure on his chest, which is alleviated after burping, and furthermore, when he walks he has a lot of chest pains, which again improve after he burps. It is not clear if these pains are related to exertion. GP is not able to find anything. Upon checkup at the clinic, symptoms are milder. The patient makes a link between the symptoms and eating meals. Additional examination by MRI concludes no ischemia." Conclusion: we investigated this patient further due to his presentation of atypical thoracic symptoms. The MRI showed no significant findings. However, more significant is that there is no evidence of myocardial ischemia. We are therefore not able to relate patient's symptoms with a cardiac cause. It may be possible that the esophagus is the cause of his underlying complaints. Check up in 6 months. A month after receiving this letter from Dr. C, Mr. D's general practitioner requested yet another referral and stated in his letter the following: "I regularly consult Mr. D in my clinic with pressure and pain on his chest on cold weather, heavy meals, and upon exertion, and the pain subsides in rest. I find that there is enough suspicion for angina pectoris. He's had a PCI in 2012, and a recent MRI showed no significant findings. Is there still an indication for a coronary angiogram? Requesting your opinion. Patient is suffering a lot, also known with type 2 diabetes, for which on medication." For context, a coronary angiogram is a test that uses X-rays to view the vessels of the chest and can determine if there are any blockages or obstruction of these arteries. In May 2018, so 3 months after the second request of the GP to Dr. C to review Mr. D was sent, the cardiologist writes in the file of Mr. D, "Was here in March, but I was not here. Went to see the ear, nose, and throat doctor. Ear, nose, and throat doctor could not find anything. Must go now to the gastroenterologist. GP thinks that the complaints are from his heart. See documentation. Last time had chest pains and pains in his arms. Is tied in the legs and joints. Conclusion: atypical symptoms for myocardial infarct. Now no indication for coronary angiogram. Plan, as before, can return earlier if symptoms are more frequent or if symptoms are during mild exertion." Mr. D attends Dr. C's checkup another 2 times, in October 2018 and April 2019. From August 2019 to July 2020, Mr. D visits his GP 5 times with the same complaints, chest pains. His GP refers him yet again to Dr. C in September 2019, and the medical files of Dr. C reads much pain of his muscles, tendons, joints, continuous pain of his chest, shoulder, arms, with any exertion or movement, pain. This afternoon received an injection in his joint. Stopped taking penicillin. Conclusion: much pain in his muscle, no joint pains. On July 2020, Mr. D's general practitioner refers him to Dr. F, a different cardiologist. Dr. F requests a coronary angiogram to detect if there are any blockages of the arteries to Mr. D's heart, and this exam is performed in September 2020 and is done in the hospital in which Dr. C works. From this exam, it is clear that there is a massive obstruction of the coronary arteries. On the basis of these findings, the heart team in which Dr. C worked accepted to perform a bypass procedure. According to the plaintiffs, had the cardiologist not sent their father to other specialists and not think that the cause of his chest pains were due to something other than his heart, then their father would have had a higher chance of surviving his condition had he received the adequate treatment. We're going to look later into what the defendant, Dr. C, stated in his defense. But first of all, let's just say this. He did not agree with the plaintiffs nor the complaint filed against him. The judges based their rulings on the following facts. It is true that from 2017, the patient presented with atypical chest pains that relieved after burping and were not at the time related to activity. However, it is also known that patients with type 2 diabetes present with atypical chest pains. With this comorbidity, the patient was in fact already at a high risk profile for cardiovascular disease. The judges also take into account that Mr. D's general practitioner had on several occasions referred back to the cardiologist for another review and further investigations because the general practitioner was very concerned that the cause of the complaints were of cardiac nature. The fact that Dr. C concluded there was no possible cause of a myocardial infarction based on an MRI that showed no significant findings falls short of making a good diagnosis. Also, given that in 2019, Mr. D complained of a heavy feeling in his arms that worsened on exertion. The defendant responded that in 2012, the successful dilation procedure of his coronary artery did not relieve Mr. D of his symptoms. So for him, the symptoms he had in 2017 and 2019 made little difference to the cardiac situation of the patient. Also, the fact that a spray under the tongue, nitroglycerin, did nothing to relieve Mr. D of his symptoms also meant that the cause was least likely to be from his heart. Even though the judges understand Dr. C's reasoning, they still find that despite a negative MRI result, a successful PCI procedure in 2012, Dr. C should have requested a coronary angiogram, as this is the golden standard in the guidelines for new blockages of the coronary arteries. And then the defendant, Dr. C, responded with the following. He agrees that the coronary angiogram should have taken place, but he had thought about it and decided not to have it done because the complications it would bring. Dr. C stated that severe complications such as a stroke, a serious bleed, or even a heart attack are serious, and was the reason why he did not consider the coronary angiogram in Mr. D. The judges agree that these are indeed valid reasons to not perform a coronary angiogram in this case. However, the judges highlight that had that been the case, Dr. C should have discussed this with Mr. D, and that both him and Mr. D should have come up with a conclusion, and this should have been documented in the patient file. And since there is no proof that this discussion took place, the judges rule in favor of the plaintiffs regarding the lack of documentation. A further remark on the documentation part was made, to which the judges highlight that in the period between 2014 and 2018, the cardiologist saw Mr. D twice a year, yet only once did he send a letter to the GP. The defendant, Dr. C, stated that he only informs GPs in the case of a new patient or if there is a change in the treatment plan or medication. And if the general practitioner wanted information, he should have requested this and he would have received it within 2 days. The judges do not agree with the defendant's reasoning. In fact, the judges state that it is important for specialists to inform general practitioners once a year or at most every 2 years, and eventually as often as needed depending on the situation. The judges do not agree with the defendant's argument that he did not need to send another letter after the one he sent in January 2018. In fact, the judges find that he should have at least explained to the general practitioner why he felt further investigations were not needed, and for that reason, the judges rule in favor of the plaintiffs. To conclude, the judges rule in favor of the plaintiffs and find that given the high risk profile of Mr. D, there were inadequate investigations that were performed to determine the cause of his symptoms. The judges find that in this situation, a warning is appropriate and it's really intended to make Dr. C, the defendant here, more alert of high risk patients who are under his care, especially those who are under his care for many years, and to make sure that Dr. C informs the general practitioners on a regular basis of his findings. Well, once again, I learned a lot. I recall a similar case of a patient who had a myocardial infarct. He came to me with stabbing chest pains similar to this case, and I also thought it was from his esophagus. He was on pantoprazole for stomach acid. The following week, I received a letter that he had been admitted at the hospital and had suffered a heart attack. A few weeks later, he attended my clinic over 3 times with pains in his chest, again of stabbing nature. They were very atypical. And in that period, he had been back to the emergency department twice, had been seen by the cardiologist, they performed several tests, and all of them had been normal, and they also diagnosed him with no risk of a myocardial infarct or no new risk for anything ischemic. So even though he's not a high risk patient, I am going to be extra alert the next time he comes into my clinic.